Good afternoon, everyone. Today, our Zoom session is about CMV, and Dr. Irfan Agha is very known to all of us. He will be leading the charge. As you all know, my name is Umar Farooq, and I need to make some announcements. I think we still need your name and email IDs for record keeping. I'm sure most of us by now, I have the emails. Keep your mics mute if possible all the times, and if you need to type in the chat or raise your hand. I think, as Dr. Agha just mentioned, that we want to keep this session very interactive. And in the spirit of ECHO's all teach, all learn approach, we will be, or we can be, on the first name basis as appropriate during the session. So without any further delay, I would request Dr. Agha to take over. And if he would like to share his screen, and it's up to him. Irfan?
Or you'd have to enable me because you're blocking me from sharing screen on the security settings.
I just made you co-host. Would that work?
Yeah, I got it.
Thank you.
All right. Good morning, good afternoon, good evening, wherever you guys are. I think we're in multiple time zones at this time, which is great. So we're going to talk about cytomegalovirus and kidney transplantation. This is a very tricky topic. I think the past 20 years, we're kind of pretty much set in one particular course of action for most centers. So we'll see how we can improve that. Before I proceed with my talk, this is a CME talk, so I do not have any relevant disclosures for this particular talk. My disclosures are on file with ECHO, and all the patients that I will use in this talk have been appropriately de-identified. So we will start with the first case. This is a 55-year-old African-American gentleman. He was called in for a kidney transplantation. He asks about his donor, and he is told that his donor is CMV IgG positive. So the patient asks, what does this mean? Does the donor have CMV infection? Where did this antibody come from? And what is my risk for developing cytomegalovirus disease? So what do you guys think? How would you answer a patient? In Pakistan, we don't have a lot of deceased donor kidney transplants, so it could be a live donor kidney transplant recipient. What if he asks you, does the donor have CMV infection? Why does he have this antibody? And what is my risk for developing CMV? How would you answer this question? Well, let's just start an open-ended discussion. This is how we'll build it up and kind of figure out what we need to do to help these patients. But why does somebody have CMV IgG circulating in the blood?
Ali, you raised your hand. Please go ahead.
Yes, for us, CMV IgGs are positive in almost 100% of donors and recipients too, when we're just doing the live transplant. So if our patients, most of them would never ask, but if they would ask us, we would just tell them that they have had exposure with this virus, and this antibody would continue to circulate in their body as a protective phenomena from this infection. Risk of developing CMV are significant if they would not have been exposed, but otherwise, if they have preformed antibodies, especially both in donor and recipient, then the risks would still be, I don't know, because the recipient would receive immune suppression. So depending on that, the immune status of the patient after the transplant, they can acquire CMV infection, but I don't know the exact incidence of CMV infection with both recipient and.
Very good. I think that's very precise. And as we go through the talk today, we will we will kind of look at some of these things unfold. So as Dr. Lane Wallace said, this circulating immune globulin is a tombstone from an infection in earlier days. So CMV, primary infection happens in children. In Pakistan, the incidence is a little bit higher than what it is in the US, but still extremely high. So a majority of the population has circulating antibodies, and we will kind of go over why these antibodies are present in the blood decades after the index infection. So when it comes to the risk for developing CMV, the antibody is a marker for, perhaps a marker for protective immunity. And an anamnestic response happens when the virus is reactivated. And basically the virus actually travels with the organs. So the issue then is the host's immunity going to be able to deal with the virus that's traveling? It may be a different serotype traveling from the donor, and that too in the milieu of immunosuppression. So that's kind of some of the things that we will talk about today. So this is what most of Dr. Lane Wallace patients go through. They have a primary infection. The virus actually de-envelopes and sends the capsid-related proteins along the microtubular network in the cytoplasm to the nuclear pores. Here, what happens is that the capsid itself now is going to stay in the cytoplasmic domain, but it spits its nucleic acids, the DNA, into the nucleus. There are some proteins like the PP71 antigen that actually travels to the nucleus separately, but once it comes in, it starts having the cell produce the immediate early and early antigens, and then the immediate early and early antigens start the viral genomic replication. So once all of this happens and we're beginning to start assembling the viral particles, the naked nucleocapsid is trafficked out of the nucleus and it goes to the endoplasmic reticulum where it is given appropriate coats, and then it is extruded from the cell. So all of these antigens are being presented on the cellular surface. So this is what actually is happening. Usually the infection is a respiratory tract infection. So on the respiratory mucosa, you've got all these cells that have got infected with cytomegalovirus. Now the body has to contain that, and the immune system engages, and the part of the immune system that engages initially is the innate immune system, and that response comes in waves. So essentially what happens is that the primary scavengers, the natural killer cells, etc., start putting up a fight, but the virus particles are picked up by the macrophage monocyte system. So over here you see a dendritic cell, which is an antigen presenting cell, and monocytes. Now, once this happens, the primary burst of activity that happens is release of Th1 cytokines, your interferons, your interleukins, so on and so forth, which start recruiting cells and start stimulating natural killer cells and resident gamma delta T cells. But then the antigen presenting cell is trafficked to the lymph nodes where they laterally stimulate CD8 cytotoxic T cells. These are released into the circulation as well, and they join the melee. Now, what you see here is the M157 antigens in mice, or the HLA-E antigens in humans. So anything that's in red here is a murine antigen, so we'll kind of disregard that. We're not mouse doctors. But once the natural killer cells, as well as the stress ligands that are being produced on these cells are picked up, the gamma delta T cells and natural killer cells start coming in and start trying to block the viral cytopathic effect. Now, gamma delta T cells are a subset of circulating and tissue resident T cells, which differ from the other T cells based on the type of molecules they have on their surface. 97% of T cells have an alpha beta, so alpha chain and beta chains on the T cell receptor configuration. These cells have gamma delta D cells, the gamma delta chains. These are actually not MHC restricted, and there are several phenotypes of these. We'll kind of touch on that. I don't want to go too much into the basic science of that, but this field of the role of gamma delta T cells in controlling cytomegalovirus infection is on fire. So all you're seeing on the left side of the panel, on the left side of this arc right now, is the primary response, where you're trying to protect the mucosal barrier and trying to hold the infection over here. But obviously the infection is going to get into the tissues, it's going to get into the circulation, and it starts finding its way into sanctuary sites. So endothelial cells, the CD34 positive cells, are a sanctuary site for these viruses. And now what happens is a secondary immune response is generated, and we'll talk about that in a little bit. And the innate system starts talking to the adaptive system. And so the CD8 alpha beta T cells, which are generated in the lymph nodes, come in and they're trying to kill the virus. Natural killer cells with particular phenotypes, and we'll go over them, are coming in and they're trying to destroy the virus as well, or the virus infected cells. We have the gamma delta T cells, and then we have antibody producing cells. So all of these are different types of effector cells which are going to try to eradicate the infection. And eventually what happens is that the virus becomes dormant in its sanctuary sites and it stops replicating. But once there is a decrease in immune surveillance, the virus may wake up again, start replicating. And in those circumstances, then these things swap those cells down again. So you can get intermittent viral replication episodes. But when this kidney is transplanted into a recipient, now there's a totally different milieu. So this is all in the context of the host itself. But once we put this kidney into the transplanted milieu, several variables change, and we'll touch on those. So now this is a complicated picture, so we're going to walk through this. Essentially, what we're looking at is antigen presentation pathways here. So just look at the central panel here. You got a macrophage, a dendritic cell, both antigen presenting cells, which are going to present antigen to T cells of different types in the context of MHC2 molecules. So a macrophage will pick up the virus particle, put it in the cleft in the MHC2 molecule. As regular alpha beta configuration T cell is going to pick it up. It is going to then start launching a proliferative response. So there will be a clonal expansion of this CD4 T cell, which then will lead to stimulation of B cells and generation of a canonical B cell response, and also generate CD8 T cells. Now, these dendritic cells in the tissues can laterally, or in the lymph nodes, can laterally stimulate CD8 T cells, again through an MHC2 CD8 T cell receptor interaction. And then these cells are going to go out and try to kill the virus infected cells. So these are the effective, these are the assassins that are generated to kill virus infected cells. Now, likewise, both of these arms are going to pull in B cells and start making antibody. They're going to lead to generation of certain types of natural killer cells. And when we were talking about BK virus, we talked about the on-off switches on the natural killer cells that are actually driven by the KIR receptors. And also natural killer cells can engage in antibody dependent cell cytotoxicity. So all we are trying to do here is, and I'm sorry, I forgot to mention that some of these inflammatory markers are going to recruit a traditional PMN driven inflammatory response as well. So there's inflammation, there's immune activation, antibody generation, cytotoxic T cell generation. And the idea is to keep this response in control. Now we're looking at a lymph node. On the left side, we're looking at a primary response. So this is one of Dr. Lanewalla's patient who has never seen cytomegalovirus before. So essentially what's going to happen is that this dendritic cell is going to present antigen to a naive B cell in the lymph node. So this is when the antigen presenting cell gets activated because there is a viral invasion in a tissue. It picks up the virus material and runs to the police station. And the lymph node is the police station here, where there's these police people sitting there. It tells them what is the identity of the invading virus. Now, then what happens is that this naive B cell, which actually is now primed because the antigen presenting cell has activated it. So this prime B cell now needs T cell help. So there's a specific subtype of follicular T cells called TFH, or follicular help cells, which then interact with these prime B cells. Once this T cell help is provided, these B cells start generating and start the initial follicular germinal center reaction. They make some germinal center B cells, they make some short-lived plasma cells which start making antibody, and they also generate some memory B cells. But importantly, these germinal center B cells go back in and start proliferating again. They undergo what is known as somatic hypermutation as well. So they're really chiseling down the antigen definition against which they're going to make antibody. And eventually what happens after this germinal center reaction is that you develop memory B cells, you develop long-lived plasma cells. So long-lived plasma cells have a specific phenotype. Memory B cells are scavenging around. Now what happens is, whenever there is exposure to a CMV antigen on cell surfaces, the antibodies that are coming out from long-lived plasma cells will try to opsonize that, and memory B cells can quickly lead to a B cell response and generate more plasma cells. So this is a much more accelerated response, which we see within 1 or 2 days. But the reason you have antibody decades after exposure to the initial CMV exposure is because you've got these long-lived plasma cells, which are CD38 plus, CD138 high, CD19 low, and they live in the bone marrow niche. When they're living in the bone marrow niche, they just sit there and chug out antibody. So that antibody is your first line of defense, and right behind that are the memory B cells. So essentially, this is the two-wall hypothesis that helps us deal with infections. And this is true for many of these childhood infections, or many of the infections against which we advise immunization. So measles and tetanus and so on and so forth. So essentially what happens is, the first wall of your defense is the long-lived plasma cell, because that's making all that antibody which is circulating. So this is what you check in your patient. When you look at it, you say, oh, he's CMV IgG positive. What that means is that they have gone through all this and they have generated long-lived plasma cells, which are now maintaining stable levels of antibody in the circulation. But if there is virus that breaks through this initial wall, you've got the memory B cells, which start generating more plasma cells and try to get rid of this infection. So this is the two-wall hypothesis that we have in taking care of some of these viral infections. And once we have antibody, if you have high titer antibody, your hazard ratio of developing CMV is very low. So this is low here is good. That means you're not developing CMV. But if you're going up like this, that means you're developing more and more CMV. So apart from seropositivity, it seems it also depends on how much antibody you have. So if you have high levels of antibody, you have more protection. If you have low levels of antibody, probably not so much, you may be at risk. So our way of looking at the risk for these patients is getting more and more refined, and we'll look at some of this. But suffice it to say, and we're not going to look at the right panel, we're not mouse doctors, we're going to only look at the left panel. So the things that actually help us in thwarting cytomegalovirus infection, apart from the antibody, is 3 different tribes of cells. One is the gamma delta T cells. We talked about them. The other is the cytomegalovirus specific alpha beta CD8 T cells. So these are your more common type of T cells that circulate, and then certain NK cells. So this looks like a complicated picture, but what I want to focus on is that the alpha beta T cell signature, CD signature is very, very similar to the gamma delta T cells. So they are they have some unity of purpose. So they are CD45 RA positive, CD27 low, CD28 low, CD62 low. That's the exact phenotype you're seeing in the gamma delta cells. And the gamma delta cells that we know of are of two different types. So the one we are really worried about, or not worried about, concerned about, once we want there, is the V delta 2 negative. These are the tissue resident gamma delta T cells. There's another class of gamma delta T cells that are in the circulation. We're not too worried about that. The signature of that is a V gamma 9 plus, V delta 2 plus type. So what we are worried about is the V delta 2 negative TCRs, which are cytomegalovirus induced gamma delta T cells. And also note, when we talk about natural killer cells, there are some things that are common between the gamma delta T cells and the natural killer T cells. So these three tribes of cells, and we can't look at cells at this point, well, we can, but we don't, are the cell component that take care of cytomegalovirus, and obviously the antibody we talked about. So in light of this, the patient asks us now, okay, I understand I have a risk for CMV infection. What can you do to reduce this risk? So in light of what we have discussed, we know that this patient, and the patient was CMV negative himself. So the donor is CMV positive, the patient is CMV negative. So he's obviously at risk, as we understand it, for CMV infection post-transplantation. So what are the different things that our centers are doing to mitigate that risk? So I think it's very pertinent to ask what centers in Pakistan are doing to mitigate the risk of cytomegalovirus infection in these patients. So Friends for Pakistan, can you educate us on how you're dealing with this?
I may say in Lahore, for the most part, the way I've been doing it basically, along with the Ahad, is that obviously the prophylaxis, usually we don't offer, but I think it becomes a problem, and people have had a lot of CMV, especially with the TIMO. There are two ATGs that are commonly given over here is ATG-F and the TIMO. For the most part, I think if they are not on, the trends in Pakistan is that we don't give antibody induction and we keep the steroids for, it's just a prolonged taper. So when we do give ATG still, when I've seen whenever we do the prolonged taper, we do get into the CMV business. But for the most part, I try to check monthly or every 2 to 3 months CMV. Again, it all depends on the pocket of the patient. But whenever we have an indication, fever or any, hepatitis or any other pneumonitis or any symptoms, we always check for that, or we can do a monthly thing. But for the most part, they are not given sort of a prophylaxis, and we keep on checking it. People who can afford, obviously we give them. We have not too many patients positive into negative. So for those folks, we do tend to give them. For positive into positives, we just watch them for the most part.
Fair enough. So you're doing a little bit of a hybrid approach where you're picking out the highest risk people, which is the positive to the negative, giving them valganciclovir or something for prophylaxis. And then the intermediate risk people, you're just doing a little bit of a stretched preemptive approach, checking PCRs if you can, or then treat for cause if we miss the infection and it precipitates with organ system disease. Okay, very good. Any other strategies that friends in Pakistan, in Karachi, and other institutions?
Hi, I'm Dr. Tasadduk, and I'm from Dow University Hospital, Karachi. And what I am using approach is I have divided, in two groups: high risk and low risk. High risk are those who are induct with the ATG and they have poor match, or they have any Luminex antibodies present. So we have given a high immunosuppressive doses. So in those patients, we are giving prophylaxis for 3 to 6 months, depending on the patient availability. But at least 3 months is mandatory in our center.
Very good. So are you taking into consideration the serostatus as well, or just the degree of immunosuppression that you're forced to afford in high-risk patients?
To be honest, like 99% are positive, but positive to negative, of course, we have to give it. But the problem is whenever we do, immunosuppression with ATG, later on they develop, CMV, because we used to do PCRs every alternate month. So we usually have something like 1,000 to 5,000 copies started if we don't give it. So then later on we realized that we should give it to everyone who is taken ATG.
Fair enough. I think Dr. Lainwala had his hand up.
Yes, at SIUT, we also do the same thing because the availability and cost of valganciclovir for us also to provide to everyone who has received a very high dose of immune suppression is difficult. So anyone who has had any symptoms that would suggest CMV, we have a low threshold to test them with PCRs. And if we have that positive, then we treat them. And then we'll continue with oral ganciclovir too. Those who like I cannot recall in anyone in recent times that who had negative antibodies in a recipient and a positive donor. So that high risk population, fortunately, we have very low. So, but that would merit prophylaxis.
Fair enough. And when you guys do prophylaxis, you're using valganciclovir. It seems to me everybody said valganciclovir. Is that about right?
Yes.
Yep.
Okay, very good. Now let me switch. Two participants raised hand. Omar, could you help with that? I don't know how to get to that on the screen. Omar, you had raised your hand, so one of them is you. So why don't you start and then see who else has got the hand
No,
up?
I think I wanted to say something. I think this is actually a good point to know that you are not seeing so your recipients, they are already CMV antibody positive. I think that really takes out a big chunk of the risk and high risk population. So similar to your experience, I think we experienced maybe more than a decade ago, we were using a lot of alemtuzumab as the induction therapy. And then in our transplant center, we saw an increased risk of any opportunistic infection, CMV being at top. And actually, we got our data published. So this was tied into the use of heavy induction therapy with alemtuzumab, because it leads to like really a prolonged phase of immunosuppression, which is like really at the higher level. So I think you are probably extrapolating similar experience with the ATG or some other risk status based immune, like whenever there is very heavy dose of immunosuppression, this makes sense for CMV to come back. I think, but I'm just saying that it's good to learn from your experience that there is you don't see a lot of CMV negative antibody negative patients, and B, you are having this hybrid kind of approach, targeted approach for high risk population. So that's great.
Very good. Any other comments before we move along? Okay. So to answer the question of what can be done, so this is one of the first studies, I think, that came out in protecting against CMV, prophylaxing against CMV. This is in kidney transplant patients, and what they did was they gave immunoglobulin to about 24 patients, 35 were controls, some of them were treated for rejection, some of them were not. And obviously people who were treated for rejection and did not receive CMV prophylaxis with CMV IgG developed a lot of CMV disease, serious CMV disease. So that was the first inkling that we could do things to prophylax against cytomegalovirus. And the first thing that was tried was passive immunity through CMV IgG. By that time, some drugs were being developed. So valacyclovir was in the market, and there was this fairly large trial looking at valacyclovir for the prophylaxis of cytomegalovirus in kidney transplantation. And you can, and the valacyclovir dose that was used was pretty hefty, 2 grams 4 times a day, a little bit hard to do, but it did show that it dropped the incidence of cytomegalovirus reactivation significantly in the seronegative group. The seronegative group was CMV positive to CMV negative, the high risk group as we would call it today, whereas the seropositive group was either a negative or a positive donor to a positive recipient. So there were about 200 odd patients in this arm, 400 odd patients in this arm, so fairly large study. Prophylaxis was afforded for 90 days. We can see that in the 90 days when they were on valacyclovir, the treatment arm did quite well. The control arm started dropping off. So a lot of them, 60, 55, 60% of them had CMV reactivation. And then once we stopped the valacyclovir therapy, there were some patients in which cytomegalovirus started creeping up. And the same thing was seen in the seropositive group. So this is the intermediate group. This is the group that our friends in Pakistan are mostly dealing with. But using valacyclovir did help in this group as well. And this was significant also. Now, interestingly, people who were prophylaxed with valacyclovir, both in the seronegative group and in the seropositive group, not so much in the seropositive group, but especially in the seronegative group, they found a significant decrease in the incidence of biopsy-proven acute rejection. And you know, there's many different reasons why this could happen. One is the non-infectious immune as well as indirect actions that are attributable to CMV. It actually triggers the alloimmune response. Also, when somebody develops CMV infection, you start decreasing your immunosuppression. So perhaps that's why it breaks through. But the incidence of rejection was much higher in the seronegative group in the placebo arm compared to the treatment arm. So valacyclovir was probably one of the earlier trials that were done. Ganciclovir was being used at that time for prophylaxis. Ganciclovir has a very poor bioavailability when taken orally, about 10 to 15%. So you had to take a gram of it 3 times a day to get the levels in a reasonable range. But then the valyl ester of ganciclovir called vanganciclovir came out, and these trials determined that it was actually as good as ganciclovir, but you needed to take the dose only once in the prophylactic regimen. And your breakthrough rates with CMV were down, and time to viremia after stopping prophylaxis was done as well. So somewhere in the early 2000s, pretty much everybody started switching towards valganciclovir for prophylaxis rather than valacyclovir or ganciclovir. So then, you know, how do you do this? How do you think about preventing cytomegalovirus infection in kidney transplant patients? So that's the question that patient was asking. What can you guys do? So there have been 2 strategies that have been used. One of them is called preemptive, and the other one is prophylactic. Prophylactic is straightforward. You start them on prophylaxis and continue that for a variable period of time, either 3 months or up to 6 months, sometimes a little bit longer in high-risk patients. Low risk, intermediate risk, you do it for 3 months. Preemptive therapy strategy is a little bit more tricky. So what you do is you do PCRs. So I was listening to some of the comments that our colleagues in Pakistan were making, that, you know, some check a PCR every month, some would check it every other month. But the way these trials were done, the PCR was done fairly robustly, you know, weekly for the first 1 to 2 months, and then every other week, and so on and so forth. Obviously, that's in a trial setting, and that also is in a setting where we're not resource restricted in getting some of these labs done. But in Pakistan, that may become an issue, but there are other offsets as well. So what would make you choose one strategy compared to another? There's still an ongoing debate on this. So we like to suppress CMV from the get-go so that we avoid non-infectious effects of CMV, and we decrease the rate of primary recurrence or reactivation in the first 3 to 6 months. And that's a noble goal. When we have people on preemptive therapy, by definition, they have to break through viremia before we start treating them. So they will all get, or a bunch of them will get viremic before we do that. So there are many different arguments that sway you to one direction or another. So let's kind of look at the medical things for the time being. The first thing is that you avoid drug toxicity when you're in the preemptive pathway, right? You're not on drug all the time. You're treated in a targeted fashion. So we pick out the people who are really actually going to get into trouble with CMV. So the thinking is it will save costs, and it does. It does save a lot of cost on the drug. It also decreases a lot of drug toxicity, like bone marrow suppression and so on and so forth. But you add the cost of those PCRs, and when you look at the PCR costs and when you look at the drug costs, they get pretty close. And I'll present very briefly a economic study on the merits or lack thereof one strategy compared to another. Now, the other issue, when you got somebody on the prophylactic regimen, now they're taking a fixed dose of drug every day, you want to make sure that they're taking their medicine. And I'll present the case on what happens when they're not taking their medicines. And then the third thing is a very interesting thing that happens. So when you've got somebody on preemptive therapy, their viremia incidence is high in the first 3 months. That's to be expected because we are letting them develop viremia, then treating it. Now, when you got somebody on prophylactic therapy, their incidence of viremia in the first 3 or 6 months till the time they're on valganciclovir, assuming that they're taking it, is essentially non-existent, very, very low rates. So it's very effective in keeping the virus replication under check. But late CME infections are more common in patients who have had prophylaxis. And why would that be? The reason that would happen is that there's some immune engagement that is required. Low-level antigenemia drives an immune response, and then these guys actually develop the natural killer cells and the gamma delta T cells, the alpha beta T cells we were talking about, as well as antibody. And so if you've got them on suppression and they don't see virus at all, they're not going to develop that antibody. So there may be some sway in there as well. But it must also be said that the PCR technique, the preemptive technique, is labor intensive. It's much simpler to put somebody on a pill and forget about it, to follow up on those PCRs to make sure that the patient is going for those PCRs, then following up on the results, and then running around trying to put them on therapy. That becomes labor intensive, and therefore a lot of units elect to go for the easy thing, the simpler thing, and say, well, let's just go with universal prophylaxis. Now, when we look at preemptive versus prophylactic strategies, there's 4 large randomized controlled trials that have been done. They used in the prophylaxis arm either valganciclovir. 2 out of the 4 units used valganciclovir. Valacyclovir was used in 1, and oral ganciclovir in 1. On the preemptive side, the trigger for therapy was CMV copy number of more than 2,000 in 2 trials and more than 400 in 2 trials. And then once they became viremic, whatever their trigger was, 3 of the trials treated the patients with valganciclovir for 14 to 21 days, whereas one trial used IV ganciclovir. And the traditional dose that we use for treatment, valganciclovir is 900 BID, IV ganciclovir is 5 mg per kg IV twice a day, assuming normal GFR. And both of these drugs have to be adjusted for renal function. And so we kind of talked about what happens. It kind of confirmed these 4 trials. Obviously, early viremia was consistently higher, considerably higher in the preemptive therapy, but we're not surprised by that. That's what that was expected. The incidence of late CME infections, like we discussed, was higher in the prophylactic arm. And the thing was that CMV disease, I mean, we're talking about antigenemia or viremia right now, but tissue-specific CMV disease, graft survival, and mortality were not different in either arm. So it's basically coming down to a cost issue, a logistics issue, and a center preference issue, but it does seem that prophylaxing against CMV is very important. So we'll just look at one of these trials. This is a German study reported in 2008. I think it was in American Journal of Transplant. That's correct. So essentially, what they did was in the prophylaxis group, they put oral ganciclovir till day 90, so first 3 months. And in the preemptive group, they were checking PCRs, and their trigger was 400 copies. And if the patient developed 400 copies, they would treat them with IV ganciclovir for at least 10 days until CMV cleared. If the CMV persisted, they would treat for a little bit longer. So here's what we find in these patients. So this is the intention to treat group. So this includes all the patients. So you have a fairly high level of viremia, which is expected. More than 50% of the patients became viremic within the first 2 months after transplantation. So this is the oral ganciclovir arm. This is the IV ganciclovir arm, but this is in the preemptive treatment group. Now, this is the high risk group, right? This is the donor positive, recipient negative group. So this is the highest of the high group. 75, almost close to 80% of the people became viremic within the first 2 months. So you're going to see viremia in the high risk group in the first 2 or 3 months if you don't prophylax them. And even with oral ganciclovir, you can see that there's a considerable fallout, even in the prophylaxis period. And then after that, there were relapses. So this is the group of concern. Now, this is the donor positive and recipient positive group, a little bit better outing. And again, the number of patients breaking through is lower than the high risk group. And then if you're recipient positive and the donor is negative, your numbers look considerably better because you're not actually having virus transmitted to you through the donor kidney, against which you may not have specific immunity. Now, it does show that if you actually look at graft loss, so these are Kaplan-Meier estimates showing time to graft loss. So the top 2 columns are uncensored for death. The bottom 2 columns are censored for death. And you can actually see that if you're giving them prophylaxis, your graft survival is better in the treated arm rather than the control arm. So this is a pharmacoeconomic estimate. So this is a complicated diagram, and I'm not going to go through that. But essentially, what they're trying to do in this is to move your cost-benefit ratio based on per patient cost difference. And how are they changing the per patient cost difference? They're playing with the drug cost and the PCR costs. So if you make the PCR cheaper or the drug cheaper, you start going into the Northwest Territory. So the green is good. If you make the PCR expensive, if you make the drug expensive, then you're going to start coming down over here. So X is the author's analysis with the PCR cost set at about 200 per test and drug cost at about 24 per tablet. And this is where Medicare comes in. So Medicare actually reimburses the test at $60 and drug at $27. So if this was where it was, it would actually favor the preemptive therapy. But this is the reality. So a private laboratory charge for a PCR is about $340 per test. So that kind of moves it into a kind of no man's land, and it becomes a little bit of a preference thing, whether you want to do preemptive therapy or you want to do prophylactic therapy. And most units are choosing to go with prophylaxis. Omar, what are you guys doing? Are you doing preemptive or prophylaxis?
Yeah, everybody gets it at the time of transplant.
Yeah. So that just makes it simpler, and the coordinators are not running around looking for tests, and you don't miss people, don't have people show up with CMV syndromes and all that. But
and I think duration is something which we can then we manage how long somebody needs to be on this type of approach. So maybe I'm sure you'll highlight that.
Sure. So essentially now this is a little bit of a more nuanced approach. So let's take a look at, the low risk group where the donor and recipient are both negative. So usually most centers would not put them on any type of prophylaxis. We'll just put them on acyclovir for herpes simplex and shingles and all that, but they would not get any CMV prophylaxis, which is probably a fairly standard practice. On the other arm here is the donor positive, recipient negative. These are the high risk people. These are the people who are going to develop disease. And in the middle are the intermediate risk people, right? So the risk of CMV disease goes from fairly low here to very high here. And therefore, in this fairly low group, I think putting them on valganciclovir for prophylaxis is overkill, and acyclovir works fine. On the other hand, in the high-risk group, a lot of people would put them on prophylaxis. And then in this intermediate group, you would do preemptive therapy. But if you look at it from the standpoint of a medical director of a busy transplant unit, this is making 3 different strata. People will have to make sure that these are coded correctly, which they usually are, and flow through the computer. Then the coordinators need to put them in these 3 different buckets, and then we have to stay on top of all of that. I think a lot of transplant centers shy away from all that. Much simpler to just put every one of these on universal prophylaxis. The cost-benefit ratio is slightly tilted away from this, but that does save in the logistic stress and burden that presents on a unit. So in the future, we will be able to do things a little bit more differently. We're trying to do things exactly as we were doing in the 90s and the 80s right now, just slight tweaks on the drugs that we use. But we would probably be able to intervene even before transplantation. If the recipient is negative, we could probably give them a vaccine. If they've got viremia or other issues, we can treat that effectively prior to donating the kidney so that the virus is completely under check. Then afterwards, we can have a smart plan, and we'll talk about some of these new things that are coming out, which would help us maintain vigilance. This is kind of a preemptive therapy approach. If something breaks through, we can give them monoclonal antibodies up front, but if something breaks through, we'll treat the viremia. If they don't have viremia, we can stop surveillance. And there are things coming out that help us with that as well. But this is the landscape of the future. We're kind of not there at this time, but the tools that would allow this to happen are probably already there. So the patient asked, how does your center deal with CMV? We already discussed this, so let's see what we did. The patient was found to be CMV IgG negative, so he was placed in the high-risk band. We gave him valganciclovir 900 milligrams daily. It was started on postoperative day 3 and was continued for 6 months after transplantation. So in our center, what we do is the high-risk stratum, the donor positive to recipient negative people get prophylaxis for 6 months, and the intermediate risk stratum gets prophylaxis for 3 months. And at 6 months, the valganciclovir was discontinued. What would you do now? So if you give somebody prophylaxis for cytomegalovirus and you stop the therapy, what do you do after that? After that, do you check on discrete intervals to see if there's late viremia, or check for cause only? So let's start with a unit in the United States. So Umar, what does your unit do?
I think if I remember correctly, so it's done on a fixed interval initially. So, and that interval decreases as the time goes. But anytime somebody is admitted for like something that even hints the CMV disease or symptoms, so in the ED, I think this is part of a standard protocol to check the CMV at that time.
Very good. So essentially, most centers gravitate to checking CMV PCR at discrete intervals. And this data comes from the insight that we had on some of these preemptive trials to see when the virus reactivates. Usually, if it is to reactivate after stopping prophylaxis, especially in the high-risk group, it takes about 4 to 12 weeks. That's kind of the window in which this starts happening. So our center's protocol is to use a CMV PCR every 2 weeks for 3 or 4 tests, depending on the risk of the patient. So these are essentially post-prophylaxis surveillance tests. Now, if somebody comes in with fevers or they've got leukopenia or other things, hepatitis or nephritis or something, then obviously we will check it for cause. In Pakistan, are you doing post-prophylaxis surveillance, or you just do after the prophylaxis is complete, you just do for-cause testing? That is, if they come in with something that suggests CME, then you will check it. I suspect it will be the latter because of cost, but I'll let our friends from Pakistan chime in.
Usually if they have any suggestive symptoms and, otherwise, again, the cost, although the cost of CMV PCR now is not that great, it's not that high, I mean to say, so we can check it. I mean, I sometimes, in people who can afford, I do quarterly. But again, mostly it is when you have suggestive symptoms or indications to check that out.
Right, and that's just fine. But yeah, your bang for the buck, your biggest bang for the buck, is in the 3-month window after stopping your prophylaxis. After that, I just check for cause. I don't check quarterly or anything like that. After that, I think the bang for the buck for a screening test at that point is very low. All right, very good. So then the question is, how do we test for CMV? So serology, we were talking about how the antibody is generated and maintained in the circulation, but it is a terrible test for diagnosis. It is a good test to stratify people, but it is not a good test for diagnosis. The IgMs are all over the place. However, there is one use which could be of some benefit in the high-risk people. So if you're trying to stratify which person is going to be at a higher risk in the positive to negative subset of having late CMV infection, you can check the antibody. And if they were antibody negative before and now have developed antibody, that would give you some comfort that this particular patient is probably going to do a little bit better. Viral cultures for diagnosis, we don't do anymore. They lack sensitivity and specificity. We do use viral cultures for tissue-specific disease, but that's a different can of worms. Antigenemia assays like PP65 and all that, we're not doing, not in the United States, not that much anymore. So the main test that we use is PCR in the plasma and whole blood. There's slight differences in how the PCR operates if you're doing it in whole blood versus plasma. The differences are slight, but one needs to be aware of them. And that is that you can actually get CMV DNA earlier and a greater copy count in whole blood compared to plasma. So if you're trying to follow the test, it needs to be done at the same lab and the same specimen. So there may be a little bit of play. So you'll say, oh, it was 500, now it's 1500, there's something going on. It might just be the specimen, it may just be the test platform. And then again, if you're treating somebody, so now we're not talking about prophylaxis, we're talking about treatment. If you're treating somebody and they're PCR positive at 21 days, and we look at some data that suggests this, if they're PCR positive at 21 days, that's the only thing that's going to tell you you're looking at the face of a recurrence there. So you may want to continue treatment and immunomodulate them a little bit more. And all tests are now being reported in international units per ml. So you want to make sure that your lab is conformed to the WHO international standards, so you know that you're clear on what you're getting as far as a report is concerned. So then comes the question of immunologic monitoring. So we've got somebody with a high-risk CMV profile, and we want to do immunologic monitoring. How do you do that? There's innate factors that you can look for. There's a bunch of them. Low C3 is one of them, polymorphisms and toll-like receptors. There's some SNPs in IL-28. There's some polymorphisms in CCL8, but none of that is ready for prime time at this time. On the adaptive immunity side, we have CMV IgG levels, and I told you how that could be important at 6 months if you're looking at a high-risk situation. Lymphopenia is a marker. Hypogammaglobulinemia, acquired hypogammaglobulinemia after transplantation is a marker. Probably just the next state of immunosuppression, that they've got too much immunosuppression on board and they may be at risk for recurrence. There's a test called Immuno, which is a CD4 ATP generation platform, which has kind of sort of fallen out of favor, so I'm not ordering that much anymore. And then there is some CMV specific immune monitoring tests. So ICS is intracellular cytokine staining. This actually stains, picks up interferon gamma inside T cells using a flow cytometry platform. So most of these tests, the first three are looking at generation of gamma interferon in specific response to CMV stimulation. And then there's a tetramer and pentamer based platform that looks at CD8 responses to CMV as well. And if you have these tests, if you've got, for instance, the quantiferon test. So the quantiferon test is an IgRA interferon gamma release assay, just as you have quantiferon gold for TB. This is a quantiferon-based test for CMV. If you have that positive, your chance of developing disease is significantly less than if you're negative. So this is turning into something that can become an additional tool, and it seems to perform better than serology in predicting who is going to get infection and who is not going to get infection. So these things are moving forward, and they're going to actually help us figuring out to develop some degree of comfort on whom to stop treatment on or whom is high risk for recurrence. So we can stratify our post transplant positive patients who have been on prophylaxis. So if the immune monitoring test comes out positive, for instance, then you know that they've developed immunity and they would be actually okay in pulling back off of prophylaxis without a higher risk of recurrence. And mutatis mutandis, if their test is negative, then you know that they are at increased risk and we need to continue surveillance. So these things are going to make our approach towards management of these patients a little bit more sophisticated. Right now, what we do is we throw them in the deep end of the pool, pull prophylaxis away, and then see if they sink or swim. So in this particular patient, after completion of 6 months of prophylaxis, the valve site was withdrawn. He was placed on secondary surveillance, and a month later, his CMV turned positive at 5,000 international units per minute. ml. So what would you do in the interest of time, because it looks like we're already at the hour mark? Now you're looking at how to treat. So this is one of the biggest trials that came out in how to treat these patients. Either use IV ganciclovir, which was the standard of care at that time, or use oral valganciclovir, which was the new kid on the block. So it's a randomized controlled trial, but it's not blinded. About 164 patients to Valcite, about 157 to IV ganciclovir. And suffice it to say, responses and recurrences were pretty similar in the two groups. So there were a total of 34 recurrences in the Valcite arm, 32 recurrences in the ganciclovir arm with similar response rates. So the oral drug was just as good as the intravenous drug, which is important. And this is also the trial in which that day 21 PCR came out. If your PCR was negative at day 21, you were probably going to be okay. If your PCR remained positive at day 21 on treatment, you're going to go down. You're going to have some higher rates of treatment failure and recurrence. So this is how these drugs work. Ganciclovir gets into the cell and gets phosphorylated through the UL97 kinase. So this is an essential step. If you don't have that, then ganciclovir will not be effective. And this is why some UL97 mutations render the CMV resistant to ganciclovir. Now, once it gets monophosphorylated, the cellular kinases add two more phosphate residues. Similarly, when cidofovir comes in, it's not dependent on the UL97 step. The cellular kinases phosphorylated. So ganciclovir and cidofovir then go and act on the CMV DNA polymerase. And if they are effective, they will shut the CMV DNA pol out and inhibit CMV replication. Foscarnet gets into the cell. It attaches to a pyrophosphate analog on the CMV DNA polymerase, and that's how it shuts that off. So if you've got alteration in the catalytic site or relative increase in exonuclease activity or something, then your ganciclovir or cidofovir is not going to work. On the other hand, if there's any alterations in the pyrophosphate site, binding site on the CMV DNA pol, your foscarnet will become resistant. But in the perfect situation, the ganciclovir, the cidofovir, as well as the foscarnet eventually go and attach to the CMV DNA polymerase, which does have the UL54 complex, and inhibit CMV replication. So let's go to our second case. This is a 56-year-old African-American female who received a deceased donor kidney transplant. She was induced with thymo, started on standard triple immunosuppression. She was high risk, donor positive to recipient negative. She was started on valganciclovir 900 milligrams daily, which was a good dose. Post-op month 5, she developed leukopenia. A CMV PCR was checked, and she had more than 4,000 copies, international units per ml of CMV. So what should be done? So essentially, what transpired here was, and I'm just kind of hurrying a little bit because of the time issue, I want to get done in a reasonable time. This patient was selectively compliant with her treatment. So we sent out a CMV resistant profile. Since she was stable, we continued her on high dose valganciclovir orally. There were no mutations found in the UL54. However, there were two populations of CMV genomes that we were picked. One had a UL97 mutation. This was a C603W mutation. The other subset of CMV was wild type. And what we think over here is happening is that this patient, because they had been selectively compliant, they were actively selecting out a clone of CMV which was resistant to ganciclovir through a mutation in the UL97 kinase. And so essentially in this particular case, there would be an issue whether this patient could be treated with ganciclovir or not. So there are different types of mutations which confer different types of resistance. Sometimes the mutation is there, but the level of resistance is very low or acceptably low. These are the patients that can actually respond to high dose ganciclovir. And sometimes a dose of 10 mg per kg twice a day has been used in these patients. On the other hand, if the mutation is significant, confers significant resistance to ganciclovir, then it's advisable not to do this. And so this patient had a C603W mutation, which increases the risk of failure of ganciclovir significantly. So we chose to pull the ganciclovir out. We treated her with foscarnet, and the patient responded completely, and she's doing fine about 6-8 months after treatment for her CMV infection. So this is complicated. This needs to be done in concert with your microbiology lab so that you know what the mutations are and you're able to figure out what mutation is important in what situation and what drugs we need to use. And there's this whole algorithm of how to treat ganciclovir resistance. So, if you're not getting the true response, or this patient was on Valsite in good doses, she should not have CMV in her blood. So now we know that they've got some form of a problem going on. So we are going to decrease immunosuppression, which we do anyways when CMV is getting out of control. And if there's severe CMV disease and we think we don't have time, you should switch them to foscarnet ahead, from the get-go. If not, we can try high-dose IV ganciclovir or oral valganciclovir and get genotype testing. We can get this back within a week, so it's not an inordinate amount of time. And if we find mutations, then we take action accordingly depending on what type of mutations we're doing. If we don't find any mutations in the UL97 or UL54 genes, then we strengthen their antiviral therapy with ganciclovir based regimens and also adjust any host factors. So this can become very, very complicated, and we need to deal with this in conjunction with our ID team. Whenever we are treating cytomegalovirus infection, we want to appropriately modulate immunosuppression, understanding that CMV can actually provoke an alloimmune response. So this is not like BK, where you can reduce immunosuppression and sit for weeks or months. In this particular situation, you have to be careful. Adjuvant use of cytomegalovirus IgG, we do it from time to time, especially if they're getting into trouble with tissue-specific disease. Some alternate immunosuppressive agents, you take the calcineurin inhibitor off, put them on a TOR inhibitor. There's some data that TORs may actually decrease viral replication itself. We can use leflunomide, and then there's some experimental agents coming when maribavir, letermovir are in the stages of development. Maribavir has been in stages of development ever since I finished fellowship, but hopefully they're coming through. And then there's adoptive T-cell therapy. So this is a phase 2 study for maribavir. These are the patients who had documented absence of response to CMV using one of the frontline drugs. So either they failed Valsite or ganciclovir or foscarnet. So they were randomized in a 1-to-1-to-1 fashion to 3 different dose levels as a phase 2 study, so dose ranging study. So either to 400, 800, or 1200 milligrams, and about 2/3 of the patients who were exposed to maribavir responded, but importantly, about 1/3 of those who responded relapsed once the treatment was discontinued. So over a period of time, we'll go around and find out what the best role for maribavir is. Maribavir is a UL97 inhibitor. And I didn't talk too much about letermovir, but it is also in phases of development. There is a trial going on in kidney transplant patients. It has been studied more extensively in the hematopoietic stem cell transplant population. So another exciting development that is on the horizon is the ability to transfuse back engineered cells. You take out T cells, adjust their receptors so that they become very specific for CMV antigens. So that's why they're called CAR Ts, chimeric antigen receptor T cells. And so this is happening a lot in the bone marrow transplant world. And we think that this will probably translate through in the kidney transplant world as well. This may be actually more relevant to lung transplant patients where CMV is a much bigger problem than it is in the kidney transplant world. And so I will talk about the third case, which is a 45-year-old Hispanic male with end-stage kidney disease due to IgA nephropathy. He received a deceased donor kidney transplant in August of 2020, standard immunosuppression. He was low risk, so CMV negative to negative, so placed on acyclovir. A few months later, he comes in not feeling well, mild leukopenia, and we check a CMV PCR and it is 531,000 international units per ml. So why do you think he developed this? He's low risk, so why does he have such high CMV in his blood? Anyone? So there's two possibilities, right? So the first is that this is a de novo infection, which is kind of less likely. The more likely scenario is that he was actually, his donor was CMV positive, had just lost the IgG. So when we checked the IgG, it wasn't detectable in blood, but didn't mean that he didn't have virus in his tissue. And so when that virus went in there, he's essentially positive to negative, and he has an open field. So the reason I'm presenting this case is that every 3-4 years, you get snookered by something like this, where in a seemingly low risk situation, you have this very high degree of infection. And so in these patients, you have to just keep a little bit of a clinical threshold to check for it. Remember that they're not on prophylaxis. If they're not doing well, check for a CMV as well. Don't forget about that. From time to time, you'll stumble on somebody with high degree of viremia. So in this particular situation, since he was symptomatic, he had very high level of virus, we placed him on IV ganciclovir for a period of 3 weeks. And after that, placed him on valganciclovir for a period of 3 months as post-treatment prophylaxis. He has recovered completely and he's doing well. So this, I think, is my last slide. I'm sorry I went over time a little bit, but I'll be happy to take any questions and obviously any discussion.
There are two questions in the chat box. First question is about when you say reduce immunosuppression, do you mean reduce MMF or stop MMF? So
yeah, it could be both. It depends on how bad the situation is. If they're symptomatic, very high levels of CMV, I stop MMF for a few weeks. If it's minor and it's just a little PCR hike, and I'm starting antivirals, I would reduce the MMF exposure for a few weeks, and then after 3 weeks, 4 weeks, put them back on full dose.
So I think the second question was really relevant to the phase 3. Why did it take 6 months for the, I think, the viral load to show up? Is that, I think it came from a Zoom user, so I assume that's the question.
I assume that we are asking about the last case.
The last page,
so,
slide you have.
Yeah, it's about 3 or 4 months. But if you look at the data that I showed about how this happens, it doesn't happen instantaneously. It takes time. Let's see if we can look at those graphs again. It would be pertinent. Take a look at this. So you see, it takes a few months for this to happen. So even if this was a donor positive or negative recipient, it doesn't happen instantaneously in all cases. It takes 30 to 60 odd days for the virus to come up. And these are the patients in which the virus is being monitored, right? We're checking PCRs. So imagine that this guy may have become positive somewhere between 30 to 60 days. We weren't looking, right? And so essentially what happens is that at some point they become symptomatic, and then we run a PCR and pick them up.
We have 2 raised hands. Thank you for, I think those were great candid answers. So Dr. Aslan, you want to go first, and then Dr. Tasadduq.
Yes, thank you, Dr. Aga. Just one thing regarding the MMF. So that's my common observation in Pakistan. When you have a CMV positive PCR, usually it gets treated while my Forteg or Celsep is on board, and they would give valganciclovir along with it. So what's your take on that? Number one. Number two is, usually if it's in the hundreds, I would just not give valganciclovir, just maybe take off the antimetabolite for a couple of weeks And to be honest, it takes it away, and then you can just slowly, after a few weeks, you can put them back on it. So that question number one. Question number two is, if you have treated CMV, you have taken off MMF recently, and then in a couple of months' time, you need to augment the immunosuppression for whatever reason, like you want to give Rituxan, you have a little bit of a rejection suspicion, all that, then how do you proceed?
Very good. Both very pertinent questions, very practical questions. So the first is, I have absolutely no critique of your approach. I think that's a very reasonable approach. If you have low level viremia, you can watch it. So you can see that some of the trigger points in the preemptive trials have been in the 2000 international unit per ml range, right? So if you've got somebody who's PCR triggered at 500 or 800 or 1,000 even, you can watch it. You can reduce immunosuppression and watch it for a few weeks and see what happens, right? And if it goes away, it goes away, nothing better. If it goes to 5,000, then you say, okay, this guy's moving in the wrong direction. And at that point, you add antiviral therapy. Nothing wrong with that. That's perfectly fine. The second question is, you've got somebody who's reactivated CMV once, we have swatted it down, but now they've had a rejection or something, and you're giving them more immunosuppression. In those circumstances, I usually put them on prophylaxis for 3 months. So if somebody had CMV and I give them thymo, if I give thymo anyways, right? Let's suppose I've got somebody who's a positive to negative, was on prophylaxis for 6 months, at 9 months developed a rejection, a severe cellular rejection, and I have to give thymo, I will put them on valside back for about 3 months.
What's your take on treating with valganciclovir with antimetabolite on board? I've never done this, but I've seen it quite often. It's being done.
Sure, it depends again on how bad it is. I mean, if you're treating a CMV PCR of 1,000 with valside, I wouldn't worry about it. I wouldn't worry about changing anything. But if you've got somebody who's got a PCR of 70,000 and they've got fevers, I'll probably put them on antiviral and I will reduce immunosuppression at the same time.
Thank you.
Dr. Tasadduq, you're next.
So my question is, if you had a CMV infection and you do simultaneous biopsy as well, and you have got acute T cell mediated rejection, so how you are going to deal this situation in which you have got a CMV PCR of around of more than 20,000 and with acute T cell rejection? This is my first question.
Yeah.
And my second question, I have 3 questions actually. My second question is, once you started treating CMV infection, sometimes you see a patient who have got multiple infections, like the patient have PCP, patient have fungal, patient have CMV. And in those cases, it is really very difficult to manage, because platelet counts are usually on the lower side and the bone marrow is already suppressed because of the Septron, because of the ganciclovir. It is really hard to what to do next. And my last question is there any role of CMV immunoglobulin in active CMV infection?
Yeah, so all good questions. So let's go over them one by one. So if you've got coexistent rejection and cytomegalovirus infection, then you're constrained to put them on antiviral and treat the rejection with steroids. I would find it a little bit difficult to give them depleting therapy if they've got active CMV infection, not just viremia, but infection. So you would probably want to avoid that. You would probably want to avoid depleting therapy if there's high-grade viremia. So you want to make sure that you're not landing the patient into more trouble than they started with. Those are the patients where you can actually use IVIG to treat the rejection as well, along with the steroids and antivirals. So that's one. The second is, when you've got multiple infections, and actually when you get CMV, your chances of getting other infections go up, especially fungal infections go up. So at that point, you're kind of meandering into the territory where you have to support the patient as much as possible. You'll have them on antivirals, you'll have them on, PJP treatment or antifungal treatment that you need to do. You can support the bone marrow with colony stimulating factors. And this is one of those situations which kind of bleeds into your third question, where use of CMV IgG would be helpful.
Okay, Thank you.
Thank you. And I do have an observation to share about a patient with foscarnet. So um, uh, as we all know, that's also a nephrotoxic medication. So we dealt with two patients with liver transplant, and they had the resistant or very stubborn kind of CMV, and the mutations were positive. So they were placed on foscarnet, and then they developed a really bad kidney injury. And I think this is how the nephrology team got involved. So that's the other kind of downside of a good medicine. That so the CMV got treated, but one patient needed temporary dialysis. Likely, both patients did not need to stay permanently with acute kidney injury. But this was one of the observation. I'm not sure how has your experience been.
Yeah, foscarnet is nephrotoxic, so you have to be very careful that you're calculating the dose correctly, and you're doing a lot of prehydration with that.
Thank you. And I see, Arslan, you have more questions.
Sorry, just one last thing. Regarding the CMV diagnostics, I think you did talk about the test. I'm sorry, I might have missed that, but did you talk about urine PCR and any role of that? I see still some docs using that and treating it post-transplant. So just wanted to make sure.
No, I wouldn't even go there. There's no role, and there's no good sensitivity or specificity in actually figuring out if this just viruria or anything that is more than viruria. So yeah, I mean the only thing that's been validated, which correlates well, is blood PCR. So I wouldn't look at the urine for this.
Thank you.
Looks like a great session, and I think the interactive segment was very powerful on top of the narrative. So we have more questions. I think we'll take that question as well. Go ahead, Dr. Sadat.
Yes, I'm sorry, I've just missed one question. I frequently see patient coming with diarrhea, and I'm suspecting that he has got CMV colitis because there are some features which are favoring CMV colitis. But if you go with the PCR testing, usually you do not detect any viral load at that moment. And later on, because the biopsy reports, take some time, and when you got colonoscopy and you get the results, you have got the CMV over there. So what do you suggest in how to, do you start clinically in your, clinical approach, or what to do in these sort of settings?
I think that's a very, very reasonable observation. Because of time constraints, I didn't go into tissue specific disease, because we'd be talking forever, because every tissue specific disease has its own nuances. Now, GI disease in cytomegalovirus is compartmentalized in a way that this is probably one of the areas where you don't get PCR signals. Sometimes you may have full-blown clinical disease, but your PCR negative. That's where index of suspicion and your clinical sense comes in. So if you've got somebody with persistent diarrhea, you should probably, once you've adjusted the MMF dose, which is, the usual cause, but if they've got this going on, you want to diagnose it and treat it based on the merit of the symptom itself. So if they've got persistent diarrhea, once you've done the basic stool pathogen studies, you want to do a flexible sigmoidoscopy or colonoscopy and get a tissue specimen and see if you're dealing with CMV. I've seen CMV fool me both on the esophagus and in the colon, because the CMV PCRs are negative. If PCR is negative, it doesn't look like CMV, but then it turns out to be CMV. And so that's a very, very pertinent observation. And it is one of those where you want to keep your index of suspicion high. Thank you for bringing that point up.
Thank you.
Okay, maybe it's time to call the day. I think I really would like to
Won
thank
the cricket match.
Australia.
All right, very good. Very good. Okay. Sorry, guys, we were competing with a cricket match today. That was bad staff work. We probably shouldn't have done that, but it is okay. I think we did all right. and there were a bunch of people on the session, so it worked out okay for everybody, I guess.
Well, thank you very much.
you.
Until we see you next time, which is going to be next month, I think sometime. So we go from there.
Sounds good. Have a good afternoon, good evening, good night, good morning, wherever everybody is. Take care.